Good evening, everyone. Myself, Dr. Vinod Kaushik, on the behalf of IAP India Digital Team, just welcomes you all. And I just shows my gratitude to our Dr. Sanjeev K. Jha, IAP President, and Dr. Ruchi Vaswani, IAP Women's Health National Head, for providing us this wonderful platform for sharing their knowledge. Today, the webinar is organized by IAP Women's Health Assam branch, and the topic of is the role of physiotherapy in COVID-19 rehabilitation by our resource person, ma'am Dr. uh, Chanam Lokeshowri. And today, the moderator of the webinar is ma'am Dr. Barnali Bhattacharya. Now, I just request everyone, please subscribe IIP India YouTube channel and other social platform of the IIP India. I just request and hand over to Dr. Barnali. Please continue with your webinar.
Good evening, everyone. I, Dr. Banal Bhattacharya, on behalf of IIP Women's Health Assam, welcome you all to today's webinar. Today we have amongst us Dr. Chanam Lokeshwri Devi, ma'am. We really welcome you, ma'am. Ma'am is an MPT in cardiorespiratory disorders. Presently, she is working as a visiting faculty in National Sports University in Paul, Manipur. She also has a work experience of more than 10 years in Sikkim Manipal College of Physiotherapy. We are really enriched and we are really uh, showing our gratitude towards you, ma'am, for joining this webinar. And I'm really hoping that this webinar will be a really enriching session for each one of us. Without much delay, I would like to request ma'am, please take over the session.
Thank you so much, Barnali, for the warm welcome. And I would like to thank the IIP Cell team to organize such a wonderful webinar so that we can share our knowledge with our fellow as well as the students, physiotherapy students. So without much taking much time, I'll just start with the topic that is. So the topic of today's webinar is role of physiotherapy in COVID-19 rehabilitation. So first of all, we will have a brief review about what is COVID-19. So basically, COVID-19 or coronavirus disease 2019 or COVID-19 is an infectious disease caused by severe acute respiratory syndrome, coronavirus 2, that is SARS-CoV-2. So it is a single-stranded RNA virus. As it is a new disease, our knowledge of the impact of COVID-19 is rapidly evolving. And much of what we know at this moment come from our existing understanding of how critical illness affect people. So WHO has classified the severity of COVID-19 as the 4 subtypes, that is the mild, moderate, severe, and critical disease. So we can just broadly categorize as 2 terms, that is a patient with mild and moderate cases according to the clinical symptoms which they are presenting, and patient with severe critical cases which has severe form of disease. So in case of patient with mild and moderate cases in the later period of rehabilitation, the patient might be mainly complaining of fatigue or not ability to do is ADL, which might resolve after some time without much requirement of the rehabilitation team as such. Or out of the total population, only a few of them might need rehabilitation services. But those patients with severe critical cases who have undergone mechanical ventilation as well as who has gone prolonged oxygen therapy with other systemic involvement, they might need a multidisciplinary approach from the rehabilitation in order to help them and in order to bring back to its previous state. So this is about how we are going to approach for mild and moderate cases. Our approach will be different than even for severe and critical cases. Our rehabilitation approach will be different. Rehabilitation along the care continuum. How we are going to proceed with the progression of the disease. First of all, in the acute stage of the disease, when the patient is in the acute stage, our main aim or the treatment aim will be mainly to increase the oxygenation. And then if secretion is there, to clear the secretion. Then the third most important aim will be to prevent other complication. So that will be, this three aim will be concentrating in the acute phase of the disease. Next, when it comes to the post-acute stage, our main aim will be to identify any impairment or any complication which has already arisen in the acute state. And then we will plan out the interventions which will help in early discharge of the patient.
Ma'am,
And in the late,
sorry to interrupt you, ma'am, in between.
yes,
Ma'am, your slides are not being shown.
okay. You are not able to
No, no, ma'am.
see the slides. Okay, I'll just share it again. Can you see it now?
Yes, ma'am. Now it's you can start.
Okay, so we'll continue from here only, no, instead of
Yeah, sure.
So what happened is in the I was there in the long-term management. So long-term, so already in the long-term management, the patient will be will be already out of the the patient will be already medical stable state, but the main emphasis or main aim of rehabilitation in this phase will be to increase mobility, then to increase the quality of life in this particular stage. So this is how we approach in the different stages of COVID. The referral procedure, basically the referral procedure is very important in case of COVID. So this is same for other diseases also, but especially for COVID here, I just want to emphasize, when the patient is in ward or in the intensive care unit, first of all, we will be doing a detailed assessment of the patient, and then we will decide whether the patient needs to be there in the same ward or same ICU, or whether the patient needs to be referred to some other setup. So once we come to know that the patient is stable enough to be referred to other setup, first of all, we will choose, or we will try to check the referral option. It might be a inpatient rehabilitation unit, or it might be outpatient rehabilitation unit, or it might be community-based rehabilitation unit. For example, the patient is stable enough and it doesn't require the critical care services. Okay, then we can refer the patient to inpatient rehabilitation unit so that the critical care bed is available for some other needy patient. Or if the patient can be discharged from the hospital and is stable enough, but still he needs some amount of rehabilitation services, then he can be referred to the outpatient rehabilitation department or outpatient rehabilitation unit. Or sometimes if the community services is enough to support the patient rehabilitation, then we can go for the community-based rehabilitation. So by weighing the pros and cons, we can refer the patient to each of the referral option. So the rehabilitation, likewise in other diseases also, the rehabilitation, it consists a multidisciplinary team, and it needs a very close coordinated work of many specialized individuals. For example, the primary healthcare provider or the primary healthcare provider, then the rehabilitation professionals, which include physiotherapists, occupational therapists, then speech and language therapists, etc. Then other members like mental health, psychosocial providers, and social care services are also required, a core member of this particular COVID rehabilitation team. Apart from that, as the need arises, according to the demand of the patient condition, other members or other specialized members like cardiologists, neurologists might be required according to the requirement of the patient. The composition of rehabilitation members, it may vary according to the availability of services in different part of the world. So accordingly, so it's not a fix that this member has to be there in the COVID rehabilitation team. First of all, we have discussed about the different classification of the COVID patients, like mild, then mild and moderate, then severe and critical cases. So mainly mild cases, it might resolve automatically without much impairment, but a few percentage of the mild or moderate cases might have some impairment also, which we are going to discuss. So mainly those patients who have undergone those critical cases who have undergone mechanical ventilation or who were on in prolonged oxygen therapy and all, they start having many impairment in the later rehabilitation stage. So what are the common impairment which we normally see that we are going to discuss now? The first one and the most very important one is impaired lung function. The impairment in lung function might be because of the direct viral respiratory syndrome. So because of the COVID infection, there is like gross tracheobronchitis, and then there is diffuse alveolar damage is there. So because of that, what will happen? There is reduction in the lung function itself. And various degrees of pneumonia might be there. Then pulmonary fibrosis might develop. Then pulmonary embolism is one of the some cases of COVID patient develop pulmonary embolism, because we know that in COVID patient there is increase in the D dimer level in the blood. So because of that, the chances of thrombus formation is there, and then there is chances of pulmonary embolism. Then it might be a direct effect into the damage to the respiratory muscle also. So there is inflammation of the myositis of the muscle itself. So the respiratory muscle, if it is involved, then it will automatically impair lung function. And or it might be because of the side effect of immobility and atrophy because of immobility. So these are the main causes which leads to impaired lung function, and this particular impairment is mainly addressed by a physiotherapist. Next, very important. Can you see the slide properly? Now, can Barnali just?
Yes, ma'am. Now it's visible. No problem.
Okay. The second very important impairment is physical deconditioning and muscle weakness. So physical deconditioning and muscle weakness, there is polyneuromyopathy mainly in case of COVID patient. So there is direct inflammatory response into the muscle, which increases the muscle enzyme. Apart from the increase in the affection in the muscle, there is also involvement of the peripheral nerves. So what happens is that when we assess, we might find there might be a sluggish tendon response, or there might be loss of sensation in a particular area of the affected nerve, or it might be a involvement of the muscle which leads to weakness and imbalance of the particular person. So involvement of peripheral nerve, because of that deconditioning and muscle weakness, it might be there. Then the second cause of physical deconditioning and muscle weakness, it might be an indirect effect because of the drugs which has been used. So steroid has been used in case of controlling in the second week of COVID patient. So it might be a side effect of steroid or many neuromuscular blocking drugs which has been used. So it might be because of that, or it may be relating with the metabolic changes like hyperglycemia or malnutrition. So everybody know that in COVID there is loss of smell, anosmia, and then loss of taste is there. So because of that, the patient is not able to take food properly. So the dietary intake might not be enough to meet the demand of the disease. Okay, so in that condition, malnutrition is one of the most common problem which arise in COVID patient. Then it might be an indirect consequence of immobility as well as atrophy. So this particular impairment is mainly addressed by physiotherapists. The third impairment, which is very important, is impaired cognition and mental health. Apart from impaired cognition and mental health, some of the patients have depression and anxiety also. So when we are going to say that there is impairment in the cognition is there, we have to always compare with the previous level of cognitive level for that patient. So in comparison, before the pre-infection and the post-infection, if there is any decrease in the cognitive level in some of the domains of the cognition, then only we can say that there is impairment. For example, an elderly patient who is 70 years old and having other comorbidities might already have some amount of cognitive impairment. So just after the infection, if we start assessing, we might presume that it's because of the COVID. So we have to have a comparative assessment. So patients can develop impaired memory, attention, concentration, and executive function. Apart from these basic functions, higher mental functions like ability to analyze, ability to make decision and all, it might be also affect. So this particular impairment is mainly addressed by the occupational therapists and clinical psychologists. The next fourth impairment is impaired communication and swallowing. So this impairment is mainly found in those patients who have undergone mechanical ventilation or tracheostomy patient and all. The impairment in communication may be related to the cognitive impairment also. So he is able to vocalize properly, but because of the cognitive impairment, he is not able to communicate properly. So we have to relate with each impairment and then we have to assess accordingly. This particular impairment is mainly addressed by a speech and language therapist. So the last one, or the last important one, is difficulty in addressing or doing daily activities of daily living. So this particular problem, it might be the causative factor might be many, or it might be a combination of many factors. So the patient might not be able to do his activities of daily living because of fatigue, then impaired cognition. Even the energy level is good also. If he is not able to comprehend or plan out his activity properly, he won't be able to do the daily activities very effectively. So it might be related to impaired cognition. It might be relating to respiratory function. So because of the dyspnea, because of he might, if he's not able to do the daily activities, so it's directly relating to the respiratory function. Then deconditioning. So because of the muscle weakness, if he's not able to do, then it's because of the deconditioning. Or low mood. In many cases, I have mentioned in the previous slide also, some of the patient has a low mood or depressive effect. It's have because of the strenuous exposure. Because once the patient come to know that he has been infected by COVID, automatically he will be having a lot of anxiety, and because of the stress in the later period, he might have a low mood. So he won't feel like doing his daily activities in a proper way. So this particular impairment is mainly addressed by the occupational therapist. So the previous 5 impairment is the main or is the common impairment which we normally get. But apart from this, other impairment, like for example, the patient is in bedridden for a long time, they might develop bed sore, or the patient has developed a stroke or a kidney failure or a like other cardiovascular problem. So accordingly, other symptoms or other impairment can also occur. But for physiotherapy as such, we will be concentrating on the main area where our services is important. So we will be concentrating mainly in the first and the second impairment. So the first one is the rehabilitation of and patient with lung impairment. So first of all, if many patients has come to us, it doesn't mean that we have to go for a pulmonary assessment for all of them. So we have to rule out, or we have to screen out who need to be assessed. Those patients who has undergone prolonged mechanical ventilation, then who has undergone prolonged oxygen therapy, or aged person, then those patients who are having other comorbidities like a kidney problem or cardiovascular, or it might be a neurological problem, then they need to be assessed. Or if they have a history of prolonged hospital stay, then we can go for a pulmonary assessment. Apart from this, those patients who are having dyspnea with minimal exertion, with minimal activity, if they are they are having dyspneic attack and they are not able to do the minimal activity, then we have to go for a this one lung assessment or pulmonary assessment, I mean to say. I just want to mention here one point. Testing lung function using spirometer is not recommended in patient in the first 6 to 8 weeks with COVID-19 because of the infection risk. Sometimes in order to know the forced expiratory flow or the forced vital capacity, we use spirometer to to the patient to check out to have a gross value. But this particular technique we are not supposed to use in the first 6 to 8 weeks. Once the infection has been controlled in the later period, we can use. And one more thing here, I just want to mention here is that whenever we are assessing the patient or during the intervention, any intervention technique also, we have to always keep in mind about the infection prevention and the control procedure. For example, we are involving or as a team member, you are involved in a manual ventilation or extubation, or for example, you're doing a sputum induction, or you're giving chest PT, or you are giving a cough assisted technique. So wherever there is chances of generation of aerosol is there, then we should always try to take precaution, like proper hand hygiene, then about respiratory hygiene. Whenever required, we have to use the personal protective equipment, then proper use or proper disposal of the waste material, the infective sputum, the proper disposal has to be there. So all these things we have to take care. The clinical presentation, of basic of a patient who is having lung dysfunction will be: the patient may experience breathlessness when in bed, when in sitting upright, or when moving small amount of activity, or for example, like dressing is a simple ADL. So with that also he start having breathlessness, then this kind of thing the patient will complain. Okay, sitting in the bed, it's a very relaxed position. That time also, without any activity also, the patient might complain of breathlessness. Patient may report chest pain or tightness or wheezes with breathing. So apart from difficulty in breathing, chest pain or chest tightness might also be there. And whoever is having any breathlessness, we should be able to explain, and the patient should be able to detect any dyspneic attack. If there is a new severe breathlessness which has come, like for example, if he's not able to speak full sentence, sweating is there, then bluish discoloration of the lip and face, then he should be able to detect those signs and symptoms and should try to seek immediate medical attention. Patient may have reduced exercise tolerance to everyday activities, walking around the hospital or inside the ward or in the home, or undertaking exercise. During the exercise, during the hospital stay only, we will be starting exercise. During that period also, the patient won't be able to do the exercise effectively. Or because of the weakness and fatigue, the patient might completely avoid to do any activities also. In most of the cases, some of the cases, the dry cough is the main symptom in case of COVID patient, but it might resolve in the early stages. In the later stages, for example, in the late stage also, dry cough may persist in some of the patients. So they might complain of dry cough in the later period of the COVID. So these are the main symptoms which lung dysfunction or reduction in lung dysfunction patient will complain of. So now we are going to discuss what are the interventions we can do to address those symptoms or to reduce those impairments. First of all, here the intervention will be basically on the base of the basic principle of pulmonary rehabilitation, like increasing ventilation, then airway clearance whenever indicated, then education for breathlessness, returning to everyday activity, physical exercise, and fitness. So each one of the technique we are going to discuss. First of all, we will start with the interventions to increase ventilation. So in order to increase ventilation, active cycle of breathing technique can be used. So active cycle of breathing technique is an exercise that increase breathing control and support deep breathing with thoracic expansion to improve ventilation of the lower lung area. So with that, it will increase the ventilation. So if the patient, okay, let me come to the second slide then. So positioning advice and support has to be given to the patient along with that ACBT. So position that allow increased thoracic expansion has to be emphasized. For example, if the patient is independent enough to sit up in bed, we will always ask the patient to sit up in the bed or chair, or if possible with the standing with the support in order to improve ventilation. For example, the patient is not able to sit for a long time, he's already like he's lying down in the bed for a long time, then in order to increase ventilation, the patient can offer a prone positioning. Prone positioning actually we mainly use in the acute stages, but some patients who are very weak and who are not able to assume this upright position, then prone positioning can be continued in this stage also. So the next one is airway clearance technique. So airway clearance technique is only indicated for patients where airway obstruction by sputum is suspected, as the technique are droplet generating. So when with auscultation, we will come to know that sputum is there or not. Secretion is there. When secretion is there, then only we will go for airway clearance technique. So all the COVID patient doesn't require airway clearance technique. So for airway clearance also, we can use ACBT. And how we are going to do ACBT, we will just go in the next slide. So ACBT is a technique which can be divided into three stages. The first one is breathing control. Then the second step is deep breathing or thoracic expansion exercise. And the third one is forced expiratory technique. So here we will first go to the breathing control. So first of all, when we are teaching the patient to do ACBT, we will first ask to assume a comfortable position. Preferably the patient can sit in a back supported chair, and then along with that a tissue paper or any arrangements would be made to clear out the secretion. Okay, then we will ask the patient to relax the neck muscle and the shoulder muscle. And for the breathing control, we will first ask the patient to inhale through the nose and exhale through the nose if possible. If he can inhale through the nose and exhale through the nose, is quite good. If he cannot exhale through the nose, then he can exhale through the mouth through a Pursley. So it should be done very relaxedly and slowly. If the patient can do it, he can close eyes and do the procedure. So by closing the eyes, he will be able to concentrate more into the breathing technique, as well as it will induce more relaxation. So this breathing control technique, he can repeat around 6 times. So once the patient has finished this first phase, he can go to the second phase, that is deep breathing or thoracic expansion exercise. So in thoracic expansion exercise, also he has to do the same thing, but the only thing is that when the patient is inhaling inside, he should try to expand the lower part of the chest. So in order to have a visual feedback, we can ask the patient to keep the hand on the chest area, on the bilateral side of the chest, and then when he is inhaling, just try to bring out your hand outward. So after inhalation, he should hold that inspiration for around 2 to 3 seconds and then expire out slowly. Okay, this particular deep breathing or thoracic expansion exercise, he can do around 3 to 5 times. So once the patient has done this first phase and second phase, he can go to the third phase, that is forced expiratory technique. So he can, in ACBT, normally we use a low volume huff or medium volume huff. So because of this low volume huff or medium volume huff, the secretion which is there in the lower airway, it will be transferred, or it will be going towards the larger airway. Okay, then we can just huff how the patient is going to do huff. A low volume huff, if the patient is doing like he will be expirating in the open glottis. So he can assume that there is a mirror in front, and then as if he is fogging the front of the mirror like that. So as if he can assume that he's fogging the mirror. So it will be a low volume mirror. Then if the amount or the expiration increases, it will be a medium volume huff. So it can be followed by a very strong cough, which will clear the secretion from the upper airway to the, then after that, he can expectorate the secretion. This ACBT technique, we can advise the patient to do for 10 minutes or 10 minutes. If it is enough to clear the secretion, then it's okay. Then, or we can advise, if the patient can tolerate enough, he can practice this particular procedure or particular breathing technique till he feels that the secretion is clear out from the lung. So he can do twice per day, that is once in the morning and once in the evening. Or if he feels that secretion is there in between the daytime also, he can practice this breathing exercise. This is how he is going to, or the patient is going to clear the secretion. This particular technique will help to clear out the secretion. But ACBT, it will be difficult for the pediatric patient to concentrate in the steps of ACBT and won't be able to do very effectively. So in those cases, we can teach the children to how to do effective huffing or coughing. And then before that, we can combine with a bubble PEEP. So after that, doing bubble PEEP, the patient can do effective huffing and a coughing technique, and then should be able to clear out the secretion. So this is about till here. It is about how, if secretion is there, how is going to clear out, how the patient is going to clear out the secretion. Next one, this is very important one, education of breathlessness, because in COVID patient, the main symptoms, the main complaint is breathlessness. So education of breathlessness is very important for the patient as well as for the caregiver and the family member. So first advice from our side should be, we should always advise the patient to stay calm. So what will happen is that the patient start having dyspneic attack, means the patient will be anxious, and because of the anxiety, the breathlessness will automatically increase. So we should advise the patient to stay calm and then think or the plan for the next step, or the next activity, what he or she is going to do. So he can use position to relieve breathlessness. Then he can practice breathing technique. So each one of the technique we are going to discuss now. So simple positioning like high side lying, then forward lean sitting can be used. Forward lean sitting also with head support and without head support. So he can choose according to the situation. And then standing, forward lean standing, he or she can assume, or standing with the back support. So this positioning technique, the patient should be able to assume any one of this position. He or she should be able to assume and then practice the breathing technique. So breathing technique, when we are teaching to the patient, so the patient should be able to choose according to the requirement, because different breathing technique have a different effect on the body. So for example, deep breathing technique are helpful when wanting to be calm in order to reduce anxiety, and all deep breathing techniques are very helpful. A pace breathing can be helpful when doing some activities which have effort. For example, he wants to do that ADL, but because of the breathing difficulty, he's not able to do, means he can break the activity, and then in between the activity, he can practice breathing session, and then so he will be pacing the breathing technique in between the activity. So that will be that time he will be able to do the activity effectively. The next one is Pursley breathing, helps the patient to empty their lung and may be helpful to remain calm and when doing a moderate level of activity. So Pursley breathing, how we are going to do is that, first of all, when the patient is doing Pursley breathing, here also assume we will advise the patient to assume a relaxed positioning, like sitting with the back support. Then by leaning forward, he should be able to relax the neck muscle and as well as shoulder muscle. Then he should breathe in through the nose and then breathe out through a pursed lip. So like pursing, in this picture, like a whistling, or he can assume that there is a candle in front of the patient, and then as if he's blowing out the candle. He should not completely blow out the candle, but so he's the blowing out or the expiration should cause only flickering of the candle, so flickering of the light, but he should not completely blow out. So while breathing in, so he can count for 2 seconds and breathe out 4 seconds. So the breathing out should be longer than that of the breathing in. So let me demonstrate this technique. So breathing in, like so breathing out should be much more longer. Let me repeat it again. While breathing in, only 2 seconds. Breathing out. So this is how he is going to do. This particular Pursley breathing, it might be difficult in the initial stage, but once the patient try for once or twice, he will be able to do it very nicely. And Pursley breathing, we will be advising the patient to do it around 4 to 5 times. So once he has done this particular technique for 4 to 5 times, after a few hours, he can repeat the same thing only. Next breathing exercise is square box breathing, or another name is box breathing. So in some books it has been I got as Navy SEAL breathing technique also. So here all the phases are equally paced. So all the phases are equally paced, but here there is this particular upper part is a inspiratory phase, which consists of 4 seconds. Then after inspiration, it will be holding, there will be an inspiratory hold phase, which also constitute 4 seconds. Then expiratory phase also 4 seconds. Then at the end of expiration also, there is the expiratory hold period, which also constitute 4 seconds. So it constitute like a box. So it's called as box breathing technique. So in the initial period, the COVID patient might not be able to hold or able to do this 4 second box breathing. So instead of that, we can advise the patient to start with the 3 second box breathing technique. But as the patient masters the technique, it can increase to 4 seconds. Then further, we can increase, the patient can increase to around like 5 seconds, 6 seconds. So according to the comfortability, it can increase the timing. So let me just show you how you're going to, we are going to do box breathing technique. So here, inspiration, hold it, expiration, hold it, inspiration, hold it, like that. So this cycle continues for some time. Okay, this cycle actually we will be advising the patient to do this particular box, one particular box cycle. He can do it around 4 times in the initial stage. After 4 times, if it is easy for that patient, then it can increase. He can do it for 4 minutes also. The main effect of this box breathing technique is that it has a very calming effect. So because of that calming effect, once after doing this particular breathing exercise, when he wants to concentrate into a particular activity, he will be able to do very effectively. Then the next point or the next intervention is returning to the everyday activity. So one of the main problem was that daily activity the patient were not able to do that much effectively. So whenever the patient is resuming everyday activity, so it should be of appropriate pace that is safe and manageable for that energy level. If the patient is having like fatigue in doing a small activity also, he should not aim for higher activity very soon. So the increase in the activity should be very gradual, and it should give enough time to the body to cope with the increased demand. So, and we have to always remind that monitor oxygen saturation level very closely. So that they should always, if they are planning out to do any particular activity, before the activity and during the activity as well as after the activity also, oxygen saturation should be closely monitored. Some patients may require ongoing supplemental oxygen as they may attempt to return to everyday activity. So ongoing supplemental oxygen is there. The activity level also has to be modified accordingly, since they will with the like supplemental oxygen. Then we can teach the spacing activities. For example, in a day, if a certain activity he is planning to do it, so in between the activities, proper rest period can be given, so that he won't reach the fatigue level. He or she should not reach the fatigue level. Or for example, if he is going to do a complicated activity, so that activity can be break down, and in between rest period can be given, so that he won't push to the fatigue level, as well as he will be able to complete the tasks very effectively. Fatigue is a common problem during the recovery. Ensure that the patient listen to their body and do not overdo it. So once the patient start doing their activity level, they tends to push to the fatigue level. So we should always remind to the patient that if you overdo it, it might deteriorate the rehabilitation process. The speed of rehabilitation process, it might deteriorate. So we have to always remind that listen to your body and do activity which you can do. Some of the activity which he or she cannot do, he should seek help from the caregiver or a family member. And then, for example, he start going to his office or the previous work, it should be a stage wise. For example, he should not, if the person is doing 9 to 5 work, then he should not just start working 9 to 5. So he should check out whether his body can cope to that particular stress or particular activity in the initial stage. For example, he can start with a half day for a few days. For example, 1 week, if he doesn't have any problem, then he can increase the timing like that. So it should be a gradual entry to the previous activity. The next one is exercise and fitness. So here, in order to reduce the contact with the patients, is always advisable to use telehealth. It might be telephonic, or it might be a video call, or it might be nowadays many apps has come up. Then it might be simple video clips through which you can teach the exercise. So in case of COVID patient, first of all, encourage a conservative approach rather than accelerated return to physical activity. Whatever the fitness level it is there for that patient, we should always try to conserve it. Then we should slowly increase the amount of intensity or the physical activity. Exercise at the right intensity can be monitored by Borg scale. Borg scale is a very easy for the patient to understand. So from 0 to 10 we can explain, and then how to mark it on the box scan we can teach. Then the intensity of the dyspnea the patient can relate during the physical activity. For those with ongoing oxygen, if we are using a graded exercise protocol, then we have to be very careful, because they are in if the room air oxygenation cannot give enough, cannot maintain the saturation, and above that we are using a graded exercise protocol, then we have to be more cautious for those kind of patients. So in the initial 6 week after 6 weeks after the COVID infection, we should always start with a lower intensity. WHO advised that we should not limit, or we should not cross beyond 4 in the Borg scale. So after, as the patient is more comfortable, we can increase later, but in the initial 6 weeks, we should never cross 4. Should aim to exercise to around 20 to 30 minutes, 5 days per week. Start with the less exercise and increase slowly by 30 seconds to 1 minute in each time. So this is a very gradual, only 30-second increment or 1 minute increment is a very gradual one. So we can offer that. So stop physical activity or exercise when the patient saturation drop more than 5 to 10% during the exercise. So nowadays for exercise testing, lower intensity exercise testing has been used in some COVID patient also, but the 6 minutes walk test has been gained much important. So 6-minute walk test, when the patient is doing it, it should not, like, if there is a drop of 3 to 5% of the saturation, then we should immediately stop the exercise that has been advised by WHO. So apart from the general aerobic exercise, so increasing exercise and fitness can be added by respiratory muscle training. So in the initial pathophysiology, the causes when we were discussing, so I have mentioned that there might be a direct relation or direct effect in the respiratory muscle also, myositis in the respiratory muscle also. So respiratory muscle training also will help to improve the fitness level of the patient, as well as respiratory muscle training can improve breathing through effort by reducing the effort through breathing. Okay, so it will help to reduce the breathing effort and help to reduce dyspnea. So the inspiratory muscle training can be done by a threshold inspiratory trainer or a power breath, and expiratory muscle training can be also helpful. So since COVID is a very new disease, so much literature was not there for the expiratory muscle training, but expiratory muscle training can also be done by reversing the end of this inspiratory IMT, as well as they can use a particular device which we call a shuffle. So by using that one, then expiratory muscle training can be done. So next one, we have completed the intervention which we need to increase, where we can increase the lung function or deterioration in the lung function, how to address, we have already discussed. So the next problem or the next impair is patients or the COVID patient physical deconditioning and muscle weakness. So how we are going to rehabilitate those patients, we are going to discuss now. So in the first 6 to 8 weeks of the infection, there is high level of fatigue and limitation of physical activity. So during this 6 to 8 weeks, the patient mainly complain of fatigue as well as limitation in physical activity. So what happened is that when we are assessing the patient, we will be assessing the basic protocol, but apart from that, more attention should be given to the cardiovascular and neurological comorbidities, which the patient, if the patient is already having, because by assessing the detailed comorbidities, it will help to modify our treatment plan as well as the rehabilitation process of that particular patient. So we can have an individualized intervention for that particular patient. So we should be emphasizing on the strength assessment, balance and assessment, pain, exercise tolerance, and the fatigue level. Home and community environment, including ability to exercise safely, indoor and outdoor. In the later period, if we advise a particular home exercise or outdoor activity, whether the patient is able to do that particular activity effectively in his environment, that we have to assess accordingly. And then if any modification in the treatment plan is there, we will modify it accordingly. So a physical examination should mainly concentrate on strength and range of motion. Only strength we should not emphasize. Along with the range of motion, we have to do it. So simple technique like manual muscle testing can be done, or just a hand grip testing, which can be done even when the patient is in the bed also. Then balance and coordination, it can be tested by a standing balance or time up or go test or a bug balance score. Standing balance, simply like a 30-second standing test can be done, time up and go. We can ask the patient to, if the patient is, we can ask the patient to sit down in a chair, then we can certainly ask the patient to stand up, walk in front for 3 meters, turn 180 degree again, come back towards the chair again, turn into 180 degree and sit down, if whether he is able to do it, that particular activity properly. So it needs a lot of balance and coordination. So we will have a brief idea about the patient's coordination and balance level. So how we are going to intervene? So as a physiotherapist, all of us know that early mobilization is the basic principle or the basic is the main thing which will deteriorate the ill effect of immobilization. So early mobilization is very important. What happens is that when the patient is in the critical care unit also, or when the patient is in the ward also, we can start mobilization which is feasible for that patient. For example, in the bed, bed activities, if the patient can do active movement properly, then we can start with active movement, or if resisted movement can be started, then we can start resistant movement. If the patient is not able to do anything, any amount of activity, then we can do the passive range of motion exercises to maintain the range as well as extensibility of the soft tissue. So early mobilization, if the patient is comfortable, then we will ask the patient to come out of the bed, then standing up from the bed, then we can ask the patient to sit near to the bed, and as well as with a supporting chair or a supporting frame, we can ask the patient to stand near the bed also. So early mobilization is same here also. The next one is education, including for fatigue and breathlessness. So how we are going to educate and how we are going to teach the patient how to control breathlessness, that has been discussed in the previous slide. So I'm not going to repeat here now. So with the fatigue, mainly we have to advise the patient, or we have to tell the patient some energy conservation technique we can teach. Then we can simplify the task, so that what will happen is that by simplifying the task, he will have enough spacing for rest, enough spacing in between the tasks to have a rest. So that can be done. Then the same advice here also, he should never go beyond fatigue level. The next one is functional mobility, including provision for assistive aid. So proper mobility, whether the patient is independent in mobility, or whether he needs an assistive aid. If assistive aid is required for that patient, then proper prescription, then fitting, whether the assistive aids which we have prescribed, whether it is possible for him or her to use in his home and community, that we have to check it out. Then muscle stretching and strengthening. Muscle, if any tightness is there, we have to go for the muscle stretching of the particular muscle. Then strengthening here, I just want to repeat it once again. In the period when active inflammation or myositis of the muscle is there, so there is increase in enzymatic level in the muscle, and then muscle pain will be there. So fever and muscle pain is the main symptom. When myalgia is there, we should never start strengthening of that particular muscle. We should give enough time to for the myalgia to resolve, then only we should start strengthening exercise. Okay, so for the strengthening, the basic principle of strengthening we can follow here also. If the muscle is very weak, then we can offer the neuromuscular stimulation technique also. Then physical exercise and fitness, here also the same protocol we can apply, which we have discussed in the previous thing. And here also physical exercise and fitness, whenever the patient is exercising in the initial 6 to 8 weeks, we should opt for Borg scale below 4. So this is about the basic intervention, how we are going to address for a deconditioned patient and a muscle weakness. So these are the main role, or what a physiotherapist can do in a post-COVID or subacute and long-term COVID patient. So any question or any doubt which... Barnali, can you coordinate if anybody is having any question? How to set lung capacity in the initial week, ma'am, if not spirometry, because it is easiest. Okay, here what happened is that in the infective stage, if we are using spirometry, in the initial acute stage, we won't be mainly concentrating on the, we won't be assessing that. For example, if the patient is in ventilated case, from the ventilation parameters only we will come to know about the lung capacity and lung function. In the later period, once the infection has subsided, then only we can check, we can use spirometry. The next question is, when people complain of Sati sir, when people complain of
Ma'am,
long
I'll
spell.
read out the question. Just one second.
Yes. Long spell of breathlessness. Is there anything specific you advise them? Long spell of breathlessness. For example, here I think it means to say about a severe case of dyspnea. So I have told in the how to control breathlessness whole concept I have explained to you, so that the same thing we can long spell of breathlessness. I think he means to say about the severe degree of dyspnea only. Am I right, Satish Sarma? No. So whenever the patient is having any breathlessness, he can assume the relaxed positioning. After assuming that particular position, he can try out the breathing control techniques. So with that, he will automatically, the dyspnea will reduce. If it is not reducing with the basic thing like a breath control and on, then he have to seek medical help immediately. Are there
There
any...
is also a second part. Is there any red flags that patient should look out while exercising and otherwise?
Yes. Okay. Red flags. The first one is the patient is having dizziness, or I have told you about sweating. Then the patient is having cyanosis, like a bluish coloration of lips and all. Then immediately it should stop. And one main precaution the patient has to do is that before the exercise and during the exercise and after the exercise, saturation should be always maintained. So if the saturation is reducing below, for example, the patient is having 94% or 96% before the exercise, and during the exercise, if it is coming as like a 86%, it means that it's reducing below 10, no, like that, then he should immediately, it's a red flag that he should stop immediately and then rest and wait for the saturation to come up.
Okay, ma'am, we'll go to the next question.
Yes.
Ma'am, how can we assess the psychological status or the mental status of an affected individual? Using which scale we can assess it?
Okay, so for assessing the psychological status and all, I won't be able to tell because I'm not expert in that field. So the clinical psychologist, I have told you that it's a COVID rehabilitation itself is a multidisciplinary team, and each one of us has a different role. So what is the role of a physiotherapist? I have explained. For psychological status and all, mainly it will be dealt by a clinical psychologist. So they will be using various type of scale, and then they will be assessing the patient psychological status.
Ma'am, next question. Who asked, ma'am, why is prone positioning important in COVID patients?
Yes, positioning is very important. So we have to remember that in COVID, it affects, the main problem is affection in the lung. So what happened is that the lung ventilation mechanism is purely dependent on the position of our body. For example, you have to remember the basic physiology of ventilation. When the pleural pressure, how it changes with different position. So if we are in erect position, the pleural pressure will be different. Then we are lying down, the pleural pressure. So because of the pleural pressure gradient, only air entry is there in our body. So that's how positioning is very important. So I just want to mention here that automatically when the patient is in supine lying and patient is in standing, the standing, there will be more ventilation. That's why we are advising the patient to go for standing or sitting position. And here in COVID patient, in acute, mainly in the acute case, we use proning techniques. Proning technique is because even though the patient is in lying position, the anatomical structure or the anatomical orientation of the lung is different. So anteriorly it has a smaller area, and posteriorly it has a larger area. So automatically you keep the patient to prone position when it's coming. Automatically, since more surface area is there in the posterior area, the ventilation will be more in the posterior in proning. That's why we are using proning in not in even in or not only in COVID patient, in any of the ARDS case, we first preference, if it is possible, we will try to keep the patient in proning. So WHO also has advised that if the in case of severe ARDS, then we should advise, or the recommendation is that we should be able to keep in a prone position from around 12 to 16 hours per day. Okay, if it is possible. So it depends on the person who is handling, like facility where the patient is, and the feasibility we have to look. Okay, so positioning is very important. So basically how the position affect the pleural pressure and the ventilation. So the answer is there only. Yes, I think the next question, can you tell me?
Okay, there is no more question as of now from Zoom. Is there any? No, there is no further questions, ma'am.
Okay. So should we wind up the webinar here? Since further question is also not there. Because I have in this webinar, I have concentrated only the like subacute and the long COVID stays. Okay, so because the physiotherapy approach of the acute stage COVID is entirely different. That's why I haven't emphasized in that acute treatment or acute management.
Thank you, ma'am. Thank you. Thanks to the moderator. It's a very wonderful, nice, knowledgeable, very precise session given by you. And I just was again thankful to the IAP Women's Cell Assam branch through that organizing this wonderful webinar. And just again request everyone, please subscribe IAP India YouTube channel and other social platform to get in touch with the more interesting webinars like this. And I just congratulate to the IAP Women's Cell Assam branch for conducting this first time webinar. And we hope that in future we will again get more webinars from your side. Thanks a lot. Thank you.
Thank you, sir.
I would now like to request Donu Kudani Kotuki to please deliver the vote of thanks.
Thank you, Dr. Chaman, Lokeshowri Devi ma'am, for such a wonderful and knowledgeable session. Ma'am, your explanation to each and every topic regarding COVID rehabilitation was very excellent and clear-sighted. Last but not the least, I'd like to thank Dr. Pallavi Goswami ma'am, our state coordinator, for her constant support and guidance, Dr. Ruchi Vashne ma'am and Dr. Sanjeev Jha sir for their continuous and never-ending support and efforts in conducting the webinars. I would also like to give my heartfelt thanks to the technical team of IAP Women's Cell. Thank you.